So I think what we'd like to do now is invite all the speakers from this morning to come up as a panel, and we'll open this up to sort of general questions from the audience of any of our speakers this morning. And while people are moving, maybe I'll start off. Kelly, two questions. Is CPIC getting into recommendations in oncology and somatic mutations?
Not now, not yet.
Do you see that as a future?
Maybe. There's been some discussion, but right now we're really just looking at germline mutations.
And the other question is, do you do any evaluation of economic impact? Do you look at economic studies to ask the question about dollars and cents saved or expended?
No, not at all.
Okay.
But I will say, if there are some good studies that have been done, we will mention it maybe in the body of the text of the guideline. I mean, I think it's still an important discussion point if that's available, but we don't take that in consideration for our recommendation because it's all about if you have that genotype in hand. So cost would not be a factor there.
Okay. Bill?
Okay, so we have a number of actionable gene-drug interactions now, but implementation is pretty modest. So just for all the panel members, who or what is the main driver in getting this implemented at any center? Who would we need to talk to if we want this to be done that's going to get it done within a particular center?
I can start. I think to really get a program going, I mean, I think we hear the word physician champion. I think you need that high administrative person that really supports pharmacogenetics. But I also think it's important to start slow. Start with one gene into a clinic where the physicians are really excited about this. And I think the antidepressants story is a great story because I think that these are physicians that I think are more open to this. And that would be the, just great example of where you could start. And then once you've kind of learned your lessons with that one gene, then you would move on to other genes or other drugs that are impacted by those genes that you've already implemented. But you're right, you really do need, I think, that kind of champion, that one person that can really support everything that you do.
Yeah, I agree, and you mentioned the clinical decision support, so you need to have the resources in-house to build those tools within whatever electronic health record you're using. So with our AMD study, our optometrist is really pushing now. It's just seeing such a great response to have the test available and as a champion.
Hi, Sue Blinsky, the Mayo Clinic. Kelly, I just have a question for you. So one of the things I noticed on your implementation list are all the big, large academic centers like Mayo, Cleveland Clinic, because we have the resources that it takes IT and otherwise to implement these things. But is CPIC proactively reaching out to the EHR vendors to start maybe working with them so this can be disseminated to smaller clinics without the infrastructure, whether it's the VA, whether it's Epic, whether it's eClinicalWorks, Cerner?
We do have on our scientific advisory board, we do have representatives from both Cerner and Epic, so we do try to take input that they've given us. I believe there's a company that's actually working with Epic now to provide these. I'm blanking on the name of that company, but so I think it's coming where the vendors would have this information and be more standard. But you're right, no, CPIC's not taking action right now.
But, sorry, just to add, if these tests are being done right now in academic centers, obviously many times patients are being referred from other maybe smaller hospitals or even from family practices. So, for example, our few thousand patients that we have, genotyped in the last years, they're mostly not from our hospital, but from other smaller hospitals in the greater area, including family physician practices. So, it can be done that these centers are doing genotyping, but the patients are basically from maybe even more rural areas, because it's so easy to maybe get a saliva test, for example, and send it over. It's not a big problem, right, to also offer or conduct such genotyping in remote areas, given the good genetic technology that we have.
So my question is related to CPIC guidelines, and in terms of applicability and how it's related to the average. We know that there are certain populations that tend to have a certain or to be unique in terms of allele frequency, And the CPIC guideline tend to be more generalized. How does the CPIC guideline take into account the differences in racial disparity in terms of allele frequency, generalizability, and especially if there's no representation of these population in these guidelines or in the studies?
Yeah, I mean, that's a great point, and I think we've learned our lesson with warfarin, actually, on that one. But I think, I mean, the best example is for some of these variants, like HLA-B star 1502, yeah, it's more prevalent in the Asian community, but you will, if your patient, regardless of their ethnicity, if you found out they were positive for this, you would avoid those drugs. And so we really write those CPIC guidelines with that in mind. But there might be some, things coming along, maybe not from CPIC, but maybe it's important you know what alleles you need to test for in certain populations. I think if you have these alleles, it's likely that they would still respond. I mean, I know that there could be other genetic things in populations that could cause them not to respond the same, but I think for now, it's really being very important to know what alleles are prevalent in your population and make sure that you're testing for those. Because if you don't test for them, then you're calling them wild type when they may not be wild type. But we do try our best to put in as much of that information in the guideline as possible, if it's available.
Question for Dr. Mueller. On the GAP clinical trial, is this the first prospective trial that you know of in schizophrenia and depression? And where are you at with the time frame?
It's not really, I would say, the first test of that kind or the first trial of this kind. There have been smaller studies like that conducted, but sometimes retrospective or, not really, in different designs in smaller numbers of patients. So we had delineated a time frame of 3 years approximately, which we would think we would need. And we started last year, 2015, so we are, we're collecting. We have about, 1/3 of the depressed patients maybe now and a little bit less in the schizophrenia population, hoping that, for 1.5 years from now, maybe a bit more, we get our data together.
Hi, my question was about since environmental factors play a role with a person's gene, do you guys see in the future that the patient would have to repeat testing, or would they just have to do one genotype testing for their whole lifetime?
Well, CPIC provides guidelines for inherited variants. I mean, that's kind of why we've stuck to inherited variants. But I think as that field grows, then yeah, it might be possible to test for these other type of variants. I'm not sure how it influences the CPIC guideline, though.
Not for a while, I don't think.
Not for a while, at least, yeah.
I wanted to go back to a question on the electronic medical records. You said you're sitting down with Cerner and Epic. Does that mean someone's working on a standardized transaction, HL7 transaction, so this could be discrete data going into the EMR so it can be used in clinical decision support? Is that being worked on?
We're definitely taking the CPIC terms, and we're definitely going to work with these groups to try to get these terms into those types of systems, yes. I'm not sure what this group's doing with Cerner, or I think it was with Epic, and I apologize. I read the news release 2 months ago, but I haven't heard much else about it since then. But I imagine that would be part of it.
Okay. And do you know, are they working with any of the, for example, pharmacy databases like Cerner owns Maltum, so Maltum, First Data Bank, somebody else where decision support for pharmacy already occurs for drug-drug interactions, other types of things. Anybody working on that kind of anything for EMRs, for appropriate alerts?
I mean, not that I know of, but I really agree with the idea of full precision medicine where you can take in all the patient's information, their renal function, their hepatic function, the drugs they're on, and to be able to, and their genetic information, and then provide that individualized dosing based on all these factors. To my knowledge, we're not quite there yet.
Okay, thank you.
This is for Dr. Mueller. So I work in child and adolescent psychiatry and use gene site testing and starting to see some trends looking at the pharmacodynamics, specifically SLC6A4 or COMT, and you didn't really talk about the pharmacodynamics, what you're seeing in your studies. And are you seeing any trends? Like I've seen more anxiety, for example, with a short transporter gene on the serotonin and less response with medications. and wonder if you're looking at those genes as well.
Sorry, let me repeat the question. Is it about why pharmacodynamic
No,
genes?
are you seeing some consistencies with the pharmacodynamic genes in your populations with mental health issues?
Yes, right. No, we do see, from a pharmacogenetic point of view, certainly some good results with some pharmacodynamic genes when it comes to response or to side effects, of course. However, most of the time, the effect sizes are relatively small. For example, for the serotonin transporter, yes, the serotonin transporter is such an obvious candidate because most antidepressants are targeting and antagonizing that transporter, increasing the serotonergic turnover in the synapse, and that alone possibly causes some of the good effects of the antidepressants. It makes people more stress resilient, and that helps during the recovery process. However, for some reasons, that is not the whole story, of course, and that gene variant alone explains only a minimal portion. We're talking about an odds ratio for maybe 1.5 or so, which is not very much. So by itself, that gene would not be a good idea to include and to promote as a response gene. It can, yes, be incorporated in a gene panel with other genes, but again, that example for the serotonin transporter, demonstrates that again these pharmacodynamic genes are more prevalent, probably as a whole. There might be many of those genes, maybe dozens of hundreds involved in response, and that where the effects are by itself probably relatively small. I hope that answers the question. All right.
I have a follow-up question for Daniel and also for Kelly based on that. And one is to elaborate on whether you view there are additional challenges in looking at pharmacodynamic genes as they might relate to disease risk or differential associations across populations. And sort of the second part of that is also that since we're seeing a large number of these pharmacodynamic variants starting to populate available test panels, whether there are plans to incorporate these or evaluate these into CPIC guidelines, and what some of the considerations are in moving from a largely drug metabolism-based assessment to getting into more dynamics.
You want to go first? Maybe I can follow up then.
Sure. Yes, I think there's several of those genes on our list right now of potential guidelines. I think the challenge is going to be what do you do with the CYP2D6 poor metabolizer that also has one of these pharmacodynamic variants. So it's this combination, and those studies just don't exist. And that's what's going to be the problem. You've got one drug, and you might have information for two genes, but knowing how to respond to both those genes without evidence to support it is very difficult. So I think that's the biggest challenge right now, and kind of leads. I had a question for you about the methylphenidate and CES1. And were there any plans to maybe add CYP2D6 to that, or is there just limited data on that?
Limited data, but we certainly can. So we've collected enough blood and consented to additional studies.
Yeah, because I think it's that we really need to start when we're doing these studies to stop just focusing on one gene. I think we're going to have to start really focusing on multiple genes. We all know it's not just about that one gene, but right now when people put these studies together, it's all focused on that one gene. But
Sam?
So my question is also regarding this added complexity. So in some of the CPIC guidelines, if patients are taking drugs that are interacting, then they are actually assigned a phenotype that is different based on those. I was wondering, it would be really hard to validate these claims, and how were these decisions made, and what are some alternatives that may have been used in previous pharmacogenomic studies?
I think that I think of pharmacogenetics as a tool that you would use, like you use renal function to, adjust the drug, you use hepatic function, other age, weight, and then pharmacogenetic, but you still have to take and consider those drug interactions. And again, there's not many studies that really tell us that if you're an ultra-rapid, a CYP2D6 ultra-rapid metabolizer, but you're taking a CYP2D6 inhibitor, it doesn't really tell us what phenotype group you would be put in. So it's just really using clinical judgment and taking all that information, including the pharmacogenetics, and applying to that one patient.
This is a question, I think, for everybody, but how would you go about picking a pharmacogenomic panel? So let's say your hospital doesn't do an in-house panel, and if you were to pick a panel, and what if you pick wrong, and then next year, there's a new gene or a new variant, then it's not on the panel that you selected. How would you go about picking a panel, and what do you think the solution is for that? Because ultimately, we need to solve that.
Well, I mean, maybe I can just answer for what we are doing with DPIC is, definitely to provide regular updates every so often, maybe every 2 or 3 years, right, Kelly? And if it turns out, yes, that there is a new variant or there's new evidence, I think it should be, this would be certainly accelerate any kind of updates or any kind of recommendation. But I think any current, recommendation and review guideline clearly states also that, yeah, this is the current knowledge, and it might well be that it's not perfect, and it might be that it changes anytime soon. So that every guideline is only provisional, I believe, right? And this comes a bit back to the notion that genetics is complex. We have a lot to understand still, and it's by no way deterministic. It's just, it just gives you probabilities at this moment and nothing else. And this will probably stay for that for a long, long time. Definitely sometimes probabilities can be higher, sensitivity can be, measures such as sensitivity and specificity can be higher in one test than the other. However, things will change. And I would also even caution that a genetic variant does the same thing, throughout lifetime. I'm pretty much convinced that the same variant that may predispose to a good response maybe early in life might be an unfavorable gene variant later in life when your metabolism completely changes. And, the environment changes. It's like an orchestra, sometimes you have music instruments that predominate, and then, you have other music instruments that predominate later on in the orchestra or in the opera. And that is certainly the case also for genetics. They might play, they might play louder or less loud, and depending on what the situation is. So we should just be, I think, cautious to, again, believe that we have understood everything, or we're close to kind of saying that's it. We can leave it as is, right? And this is why we still we'll be working, I guess, on this CPIC, Kelly, for hopefully many more years.
Yeah, and I agree with what he said, but I think a practical way to address this now that's why we've got this CPIC list, right? It's got all these genes, and we try to at least put it into a CPIC level, because you got two things to worry about. What genes do you select? What variants do you put on it, right? And so if you look at our list, we've at least attempted to find all the genes that we think would be actionable in the near future, or that are actionable now. And then variants, we've also given you the allele frequencies for these. And so I think, whatever your point, whatever cutoff you want to say, what your frequency of that allele in your population would be, probably needs to come into consideration on what variants you include. And then we also include if there's function. If it's an allele that's very rare, we don't really know the function, it's not really going to be clinically relevant anyway. Do you test for it? I mean, that's the big question. And so you just really have to look at these lists and kind of weigh what your options are to decide which ones you really want to put on that test now.
One question for anybody on the panel, and that is, it seems to me that the medical systems is slowly clashing. In one sense, third-party payers, Medicaid, have withdrawn their support for some of these pharmacogenomic panels. On the other hand, I might argue for the highly actionable ones, I want the physician to have liability to understand what they should be testing. So I think there's a clash here. So how do you resolve what is covered what the physician is responsible for based on recommendations, particularly high priority recommendations, one might argue a physician should pay attention to those types of genotypes. Are they liable?
And we are in this tough place where we're having this discussion now, assuming that no one's been tested. At some stage, more people will be tested from different venues, and we've not discussed the portability issue as well. So we've got this information. How do you move it from one health system to another as somebody moves health systems? That issue of liability is very interesting. Whether or not, they should, obviously if you have the information, you need to act on it. But what do you do if a third-party payer is not going to cover it?
Yeah, I guess I'm not aware of any case at this moment where, someone has been sued or something for not doing a genetic test of those that we discussed here today mostly, but it might come up at some point. And however, I guess there is still no clear regulation and no kind of I think, it's not part of the curriculum at this moment. So how do you determine who is responsible? Ultimately, of course, education will help, but ultimately, at this moment, the FDA, and we maybe have someone here to comment on that, but at this moment, it looks like the FDA has not really been having guidelines or having the kind of, tools in their hands to determine whether genetic test is a good one or not, or when to do the genetic testing. They kind of tell you in the labeling, if you are a poor metabolizer, do this and that. They don't tell you how to get tested and where to get tested and which alleles you should genotype and so on. So we're still in this vacuum, I guess, and CLIA just tells you, which, will give you information how to maybe use quality controls in your lab to make sure that you genotype the right variants. But still, beyond that, there is no other regulation that I'm aware of which is currently addressing that issue of how to make sure that people are informed and what to do in case people were misinformed or whatnot. So I guess it's still in the process, pretty much.
And then we're at the stage of creating further health disparities, of course, where if third-party payers don't pay and people can afford to pay out of pocket, they get better health care, which is not a good thing.
Bill?
I'm just wondering, as the infrastructure is being created to deal with genetic information, if we really should be thinking about moving towards sequencing. In creating panels, you're going to be looking at common variants that are going to be somewhat population specific, and you're going to be completely ignoring rare variants. Now, there's always the issue of determining functionality, but certainly for things like splice site variants or frame shift or nonsense mutations, you can certainly ascribe functionality to those. And as information becomes more available, as we find out promoter sequence variants and things like that, you're going to be constantly having to upgrade these panels. And as you look out at in different healthcare providers, everybody's going to have a different panel. You're not going to know whether someone was necessarily covered for certain variants, especially when you're dealing with different populations. And if we should really right now be thinking about how we're going to step up to just doing either whole genome sequencing or at least whole exome sequencing, so we can start thinking about picking up these different variants that are going to be missed in panels.
I completely agree.
But no one's really talking. I mean, everyone's talking about trying to create the latest panel, and I mean, does there need to be more promotion at this point? I mean, it creates lots of issues, and where are you going to store all the information and all that stuff? But this is the time to start doing that, and not later on when you have to redo the whole infrastructure again.
I think you bring up a great point. Sequencing makes a lot of sense, but you're right. It does bring up a lot of practical issues that people aren't really ready to deal with yet. What do you do with these very rare variants that might have no functional consequence at all versus the ones that might? How do you determine this when it can't be tested because it's been found in one patient? And then, of course, we have 2 copies, so what if they're heterozygous? I mean, there just becomes a lot of issues that I don't know. We might get a lot of patients that have these rare variants, we don't know what to do with them, and we end up calling them indeterminate in our medical record because we can't really give them a function. Can't call them normal because they're not normal, but we really can't give them any guidance on what to do with the information. So I think that's, from right now, this standpoint, it's how do you respond to these rare variants if you do have them, and I think that's why people are still going with that panel-based, where you're only testing for variants in which you have information for.
Yeah, and sorry, Kelly, maybe another example is the situation with CYP2C19, which we recently, have seen that, between normal and rapid, between normal and ultra-rapid metabolizers, those who are ultra-rapid are homozygous for the star 17, but then there are people who are heterozygous for the star 17. And so just recently, this new class of rapid metabolizer, which is between normal and ultra-rapid metabolizer, has just been created recently, right? It hasn't been, that was maybe last year or so, right? And so, you can see how things are dynamic, and how therefore, it's important to update and to kind of validate research and results further.
So my question is, so I feel like we've talked a lot about how to transition pharmacogenomics into the clinical setting, and also how we need to do more studies to begin to associate genes with different drug interactions as well as disease phenotypes. And so my question is, as we are creating new software systems to allow for us to integrate pharmacogenomics into our current healthcare software systems, is there any chance for us to use all of the data that we accumulate for a study in itself? Does that make sense?
Yeah, so I can answer that from Emerge, possibly. Most of the Emerge sites, as I said, in Marshall, we were one of them. I always say learn from what we did well and what we did wrong. We initially collected those samples in a non-CLIA certified manner. We actually did the phlebotomy in the normal clinical lab, and then split the samples off, and the samples that were being collected for routine blood work for the physical went to the clinical lab, and the ones for our biobank went to the research lab. Not CLIA certified, we're not allowed then to put them in a medical record for clinical purposes, unfortunately. For some studies that have prospectively collected them using their CLIA lab, then they can go ahead and put in the medical record, and some sites are doing that. So Geisinger is one example of one of the Emerge sites that's doing that.
Do you mind if I ask just one more question? Because I think I might need to clarify it a little bit. So I go to the doctor and I have a certain disease, and they have all of my genetic information in the system, and they're able to see, we obviously know certain genes are associated with certain diseases, but we have me as patient 1, and then we'll be able to look at all the other patients in the system, like 50,000, maybe more as it grows, as the software grows. So being able to see maybe there are 20,000 people that have the same disease as me, and then being able to cross-reference all of our genomes like across each other. So kind of essentially doing a GWAS in the software system.
Oh, and so that's exactly what Emerge is doing.
Oh, okay.
Yep, and we call it a PHEWAS, so turn it the other way around. So starting with the phenotypes, and then what's in common across the genotypes. And Emerge now has, about 100,000 patients with genotype GWAS, and then all the phenotypic information available from ICD-9 codes for the most part, in labs and some natural language processing. And then they're able to do that cross as not going to be a definitive hypothesis testing, but really more hypothesis generation.
Great, thank you.
All right, let's do 2 more quick questions.
Okay, thank you. This might be more of a topic for this afternoon, but I was just wondering, and especially, looking at psychiatric meds, let's say it's the antidepressants, are there any studies that look at doing the genetic testing and whether you're a rapid metabolizer or a poor metabolizer, and what impact this ultimately may have on medication adherence and compliance?
So you want to?
No, you go.
Okay, good. So the question was, if there are studies currently going on which are, looking how poor or rapid metabolizers, let's say, do perform when they've been treated on antidepressants? Yes.
I just use that as an example.
Sorry?
that was just the example that I...
Yeah, right. No, there are studies around, many studies actually, that have been, looked at maybe different antidepressants, but all of the antidepressants which are targeting, which are metabolized by let's say, CYP2D6 or so, which are many. And yes, there have been, smaller studies, larger studies, and studies using different methods, different genotyping, different classifications sometimes of who is now a rapid or not a rapid or a poor metabolizer. And yeah, so there is, these studies exist, and they've been, they keep on being done. And these guidelines are actually reviewing each single publication at a time, based on the medication, and this is what is then summarized in these guidelines that Kelly was talking through CPIC, but not just of course antidepressant, and not just CYP2D6, but other genes and other medications as well.
I would invite you to talk to the people at AssureX, because they recently published a paper on the impact of their genotypes on compliance, for example. So the people at AssureX probably direct you to the publication they had on that.
Thank you.
All right. We have time for one more question.
Liz Bell from Mayo Clinic. So you've talked about how CPIC, they look at how to implement pharmacogenomics, but not whether. Is anyone talking about, or systematically, whether we should implement it? Like, at what instances? Are there people coming together with guidelines for that in a systematic way?
I think that, and I always think of this as I think the best group to do that would be the disease-specific guidelines, because they're the experts in that disease state, really. I don't see it yet. I think they do. There are some cases where they've said not to genotype. But yeah, I think that as this becomes more useful to clinicians, you'll start seeing these pop up in those kind of disease-specific guidelines. There is a group, though, that does. I believe there's, but I'm blanking on that group. Sorry.
All right. Well, join me in thanking our panelists.